Kanchan, the stage is all yours. You can.
Thank you. Thank you so much. Thank you for your kind words, Dr. Dilip Parke sir. Sir is like our father figure. And कभी भी कुछ भी problem है, sir काहीतरी. So he is always the person we go to. छोटे छोटे problems साठी सुद्धा. So dear friends, today we are going to have a deep dive into fertility aspect of fallopian tubes. We have learned fallopian tubes since our MBBS, MS, Obsgyne, but today our focus is totally on fertility related aspects. What is the best thing that we are going to do, and what are the recent recommendations regarding the tubal factor of infertility. So कुठे पण बोर वाटायला लागलं कारण की थोडंसं लॉंग प्रेझेंटेशन आहे बिकॉज वी हॅव केप्ट more of evidences, more of papers. So please let me know. I'll just kahi slides I will just go through, and some slides which are of practical importance that we will discuss. If at all anything that anybody want to discuss, if they can stop me, we will discuss that and then we will go ahead. So yes, let's discuss. Yes, myself, Dr. Kanchan Durugkar. Presently, I am working as a medical director at Grace IVF Moshi, Pune. So, coming to the causes of infertility. So, we all know this pie diagram. 30% is the male infertility, 30% female infertility, 10% both. Unexplained is increasing. Earlier, we used to say 10%, but now unexplained is around 25%, and 5% are the other causes. Of this 30% female infertility, we see 30% is the tubal factor. 35% is ovulatory dysfunction. Of course, PCOS, anovulation, these things we face more in our day-to-day practice. And of course, low AMH, which is again a rising, cause of infertility. Low AMH, which we will be discussing in the coming, lectures. Endometriosis and uterine factors like septated uterus or fibroids. So these are the causes of female infertility, of which we are going to focus today on only tubal factor of infertility. So let's go back to the basics. So normal fallopian tube anatomy, this we need to know because we do laparoscopies, we do HSG, SSG. So normal anatomy, what are the points we need to know that we will discuss here. So fallopian tubes, it is named after Garbile Fallopi. Normal fallopian tube extend laterally. Just a minute. Yes, extend laterally from lateral margins of uterus to its lateral ovary. Measures around 10 centimeter, 1 to 4 mm wide luminal diameter. So it has 4 parts. That is the intramural part, which is more into uterus, isthmus, ampulla, and fibria. So intramural part, it is around approximately 1 centimeter in length and 1 mm in diameter. Isthmus is the narrowest portion of the fallopian tube with fewer mucosal fluid and thick muscularis layer. It is 2 to 3 centimeter in length and 2.5 mm in diameter, and it is densest muscular segment of the tube. Then ampulla, it is closer to ovary. Tube widens to form an ampullary segment, which is usual site of fertilization. So ampulla is the site where the fertilization occurs, and it accounts for over 1/2 of the total length. That is, it is around 6 centimeters. The diameter of the ampulla is around 6 mm. Infundibulum, it is a funnel-shaped open end of the uterine tube with the fimbria, which opens into peritoneal cavity by its abdominal ostium. It's approximately 1 centimeter. So fimbria suspends over the ovary by fimbria ovarica and captures the ovum once it is released. So coming to the layers, there is a mucosal layer, and then there is a muscular layer, and outer is the serosa. So mucosa, it is there are the longitudinal folds becoming increasingly convoluted towards the distal end. So this mucosa, why we are studying, because again we are going to learn the pathologies related to it. Then on light microscopy, single layer of cuboidal or columnar epithelium which appears pseudostratified because of the crowding of the cells of different heights. So two major cells are ciliated and secretory cells. Ciliated cells are found predominantly on apex of the mucosal fold. So as you can see, there are two types of cells. So ciliated cells are more for the motility that is there for the sperms and embryos. So tubal function, coming to tubal function, the proximal part of the fallopian tube. Are you all with me? So we are on the tubal function. It's a very important slide. So proximal part, there is entry of spermatozoa via tubal ostium. Then in the intertubal circumstances, transport of gamete and embryo, sperm capacitation, fertilization, embryo development, protection against stress. So these all things are happening in the isthmus. Then distal portion of the fallopian tube, ampulla and infundibulum. Here the oocyte is captured by the fimbria. So fallopian tubes forms the conducting channels for the gametes and embryos. Ampulla promotes fertilization, nurtures the gamete and embryo, and ensure the timely passage of embryo to the uterus. So it is the main thing that we are studying today, and the patent healthy fallopian tubes are hence important for fertility. Now, tubal pathology, as we already discussed, that it contributes to 25 to 35% of the female factor infertility and 11 to 30% of the infertility in general, depending upon the population characteristic. Main cause of tubal infertility is salpingitis, and it accounts for more than 50% of the cases. Therefore, prevention, diagnosis, and management of the tubal factor dependent subfertility is important. Now coming to causes of tubal subfertility. They can be congenital and they can be acquired. In acquired, it can be proximal, mid, or distal tubal diseases. Now coming to proximal obstruction. Now we have seen the various tubal parts. Now we are coming to the proximal tubal obstruction. So there can be pseudo obstruction because of mucus, plug of mucus or amorphous debris, mucosal agglutination and viscous secretion, or cornual spasm, which is most commonly seen while doing HSG because of pain. True anatomical blockages can be because of salpingitis systemica nodosa, PID, endometriosis, cornual polyp, and intrauterine synechis. Then coming to mid-tubal disease, it is commonly caused by PID, endometriosis, or prior surgery related to inflammation, adhesion, steno-occlusion, bullous termination, scarring, fibrosis of the tubes. So this can be the reason for mid-tubal disease. Distal tubal disease, 85% of the tubal infertilities are due to distal tubal disease. This include hydrosalpinx and fimbrial phimosis. We generally see this in the HSG report, or even if we are doing laparoscopy, there also we see hydrosalpinx is an end stage distal tubal disease where the distal end are occluded and stenosed fimbrial opening due to adhesions resulting in the fimbrial phimosis. So causes, what are the causes? Again, for the distal tubal disease, there can be PID, 85% of the STDs like Neisseria, chlamydia, mycoplasma, and 50% can be heterogeneous. Tuberculosis in India, yes, tuberculosis still has, increase. There is a prevalence, and tubal diseases are due to genital tuberculosis. Peritonitis may of any cause, tubal damage because of previous surgery, or endometriosis. So this can be the reasons for distal tubal disease. So in distal tubal disease, generally we get is the hydrosalpinx and fimbrial phimosis. Going ahead. So iatrogenic causes, yes, we day in, day out, we face these patients that their tubal ligation is done, tubal sterilization is done, and the baby has some, incidents, and then they come to us for, pregnancy, further pregnancy. So tubal sterilization, we have seen patient getting tubal sterilization at the age of 26, 25, 26 also, because of early marriage, and then family is completed and something happens to the kid, and then they come for the again fertility. So these are the important causes that we see in our day-to-day practice, that tubal sterilization causes irreversible infertility unless tubal patency is restored. Solfingectomy, of course, for bilateral solfingectomy for ectopic gestation or tubo-ovarian pathologies often needs ART to conceive. So these are the iatrogenic causes. Now, coming to the characteristics and diseases of proximal versus distal tubal disease. Proximal, here the proximal the disease is the proximal here the Tube is short, lumen is narrow, and few ciliated and more secretory epithelial cell and amorphous material salpingitis systemica nodosa, and these are the causes. Amorphous material salpingitis systemica nodosa, endometriosis, and polyp. In distal, generally it is long tube involvement, wide lumen, and there is no muscular there. More ciliated and secretory epithelial cells are there, and distal more of the time, most of the time, the infection is the positive things. This is the paper. So here they are saying of what are the risk factors for tubal infertility. So sociodemographic characteristics, again, when there is a high risk of PID, like in the patients where there is a high risk of patient is having high risk of pelvic inflammatory disease, chlamydia trachomatis leading to tubal infertility. There is increased prevalence of ectopic pregnancy, like in the patients who have intrauterine devices, uterine fibroids causing local compression or occlusion of the tubal ostium, or implantation failure, history of surgery for ectopic pregnancy and appendectomy, chronic pelvic pain, and diabetes. So these are the risk factors. Then here in this, we have seen that the patients with pelvic surgeries, then diabetes, chronic pelvic pain, chlamydia infection, uterine fibroids, these are more prone to have tubal infertility. While those using barrier methods of contraception, monogamous marriages, they are less likely to have tubal infertility. So which patients we need to have a high suspicion that these patients may have tubal infertility or tubal cause of infertility is these are the patients which have more repeated incidences of PID. Please mute yourself. Yeah. So more incidences of PID, chronic pelvic pain, or they are the diagnosed cases of endometriosis. So these are the patients in which we suspect the tubal factors. So when do we evaluate for tubal factors? So patient is coming to my OPD. They are saying there is an infertility of 1 year. They are trying for 1 year. Should I directly go for tubal testing? Should I directly go for her HSG or SSG? Let's find out the answer and what the recommendation says. So when should I do? Fallopian tube function and patency is a component of initial triad of diagnostic investigations for infertile couple, third in the line after evaluation of semen and ovulation. So dear friends, it is not that always in the first visit only or first consultation only you ask the patient for getting their tubal testing done. You can ask the patient to get their semen analysis done, ovulation studies. We can do 2 to 3 ovulation studies, and if at all the patient doesn't conceive in that, then we can offer them for the tubal testing in the form of HSG, SSG. So directly going for tubal testing in the first setting depends. Of course, if the patient's age is on the higher side, sperm count is on the lower side, we need to, we need to treat the patient aggressively according to her situation, then maybe we can consider. But if the patient infertility is not long standing, then first we need to check for their ovulation, semen analysis, and if they are not conceiving with that, then we can go for tubal function testing. So it should be suspected and ruled out when there is a history of PID, endometriosis, prior pelvic surgery, and ectopic pregnancy. So this is the high suspected cases or high risk cases. Test of tubal pregnancy and function is recommended initially when the woman's history, examination, or ultrasound is suggestive of high risk for tubal disease. So when we do the basic ultrasound, that is we call as a baseline scan. So in the baseline scan, if we are suspecting, we are suspecting there is some tubal pathology, then only in the initially we ask the patient to do for tubal patency testing and function. And if she is considered unlikely to have tubal pathology, dear friends, this is the message I want to give, that if she is unlikely to have tubal pathology, then evaluation of tubes is done only if she does not conceive at least 3 months in spite of satisfactory ovulation and natural or artificial insemination around ovulation. So this is very important. So coming to the RCOG guidelines for investigation of suspected tubal and uterine abnormality, HSG, still today, HSG is most commonly used investigation because again, because of affordability of the patient or because of accessibility. So patient go by themselves. So HSG is still today, it is most commonly test done for tubal patency. Okay, it should be offered when there is a no suspicion of PID. Of course, when we are asking the patient, then we should always rule out whether patient is having any pelvic pain, whether patient is having any active discharge, foul smelling discharge. So any suspicion of PID is there, then we should first treat the PID, and then we should subject the patient to HSG, because again, if we are doing it in the active infection, we are actually spreading that infection in the peritoneal cavity. Then endometriosis, previous ectopic pregnancy to screen for tubal occlusion. Then where available, hysterosalpingography, contrast ultrasonography. I'll be speaking more about this. SSG, or we call it as a HIOSCI, should be considered as an effective alternative to HSG. When comorbidities are suspected, then laparoscopy with chromoperturbation is offered. So, dear friends, message from this presentation should be clear that laparoscopy should not be advised for tubal testing. It should not be the primary investigation offered to the patient for tubal testing. Most of the time, we do, like, if the patient is not conceiving ovulation study, we directly subject the patient to laparoscopy. But remember, dear friends, it is an invasive procedure. We are giving the scar to the patient. Tubal testing can be done with the minimally invasive SSG or HSG. No need of laparoscopy is there. Good sonography will rule out most of the things. Okay, and so if at all you are suspecting some other pathologies like endometriosis, you are suspecting fibroid, you're suspecting some other things, then only go for laparoscopy. Otherwise, it should not be the test for tubal testing. Do not offer hysteroscopy as a part of clinical evaluation unless indicated. If you're suspecting some polyp, you're suspecting some, septum on your 3D, 2D or 3D sonography, then only hysteroscopy should be offered, of course. So coming to X-ray recommendation, X-ray workshop 2000 put forward 3 categories of test. So semen analysis, tubal patency, and test by HSG or laparoscopy, and the test to detect ovulation. So 2008 guideline recommends that semen analysis and ovulation assessment before the test of tubal patency should be performed. So women with comorbidities should be offered laparoscopic assessment directly so that any treatable tubal or pelvic pathology should be evaluated and managed at the same time. I hope I am conveying everybody. Are you all with me?
Yeah, Kanchan, very
Yes.
much.
Okay,
Very
okay.
much.
Thank you so much. So coming to the fertility evaluation and infertility committee opinion. So these are the 2021 opinion by again ASRM. So what are they saying? That routine tests for fallopian tube patency should be HSG, then SSG and chlamydia antibody testing. Test not routinely recommended are laparoscopy with chromoperturbation. Other consideration, laparoscopy with chromoperturbation is appropriate if the surgery is already performed for separate indication, and if there is a chlamydia antibody test positive, then it may require further evaluation and confirm that the tubes are non-patent. So these are the ASRM recommendation 2021. Now coming to tubal assessment test. So pelvic inflammation and acute PID, as I already do, there's an absolute contraindication. Evaluating for pelvic infection, CDC criteria for diagnosis and to manage the PID is important. And even though laparoscopy is gold standard to diagnose salpingitis, most 20% of the PID may show no evidence of salpingitis. 50% of the PIDs are heterogenic with endometrial curettage biopsy or HSG. Intrauterine contraceptive device insertion may being a main causative for procedure. Now coming to PID, it is the most common cause of tubal diseases. 85% are due to STD, as we already discussed. PID compromises a spectrum of inflammatory disease of upper female genital tract, including endometritis, salpingitis, tubo-ovarian abscess, and pelvic peritonitis. And organisms are generally Neisseria and Chlamydia trachomatis are often implicated. So what is the pathophysiology? There is a tubal damage is a very common sequelae of PID with incidence of tubal occlusion being proportional to number of episodes of PID. So if there is a single episode, the incidence is less, but if there is a multiple episode, then the tubal, along with the tubal damage, there is a tubal occlusion. So tubal damage can ultimately lead to infertility and risk of ectopic pregnancy. Of course, we have seen when we routinely in the day in day out practice, when we operate the ectopic, we see some adhesions. So there is some PID which is leading to the ectopic pregnancy because there is some ciliary damage. Embryo is not, going properly into the uterine cavity, and that's why the ectopic pregnancy. So always ectopic pregnancy will have some or the other tubal pathology. Ectopic pregnancy will not happen without any pathology. So delay in treatment can lead to chronic pelvic pain. So here to diagnose endometrial biopsy showing endometriosis is more specific. MRI showing, the thickened fluid filled tubes with or without free fluid, TO mass. These are the typical features. We can make out this with the good transvaginal 2D, 3D sonographies also. And on laparoscopy, we can see tubal hyperemia. Chlamydia antibody. Chlamydia is the most common infection for tubal disease. So chlamydia antibody test we can do. And here, but again, the positive predictive value is less. So in this case, NAT is the sensitive test. Will not go into very detail of this, but yes, we can perform this test. Coming to genital tuberculosis and infertility. So fallopian tubes are involved in almost all, more than 90% of the patients with genital TB, and involvement is usually bilateral. Various types of TB salpingitis, endosalpingitis, that is heterogeneous route, starts from endosalpinx and thicken and enlarged and tortuous tubes we can see. So unilateral or bilateral pyosulfings also we can see where there is a caseation of the tubal wall and cheesy material. These all things only we can diagnose at laparoscopy actually. In HSG, what findings we get, we are going to discuss that. But there is pelvic adhesions, TO mass, hyperplastic edematous, or tubes may be totally destroyed, fusion of the papillae of the endosalpinx, and chronic endometriosis. These are all the laparoscopic finding. If we are going for laparoscopy, we are suspecting for tuberculosis, we are going for laparoscopy, then we can see all these findings. So exosalpingitis, I have put some pictures over here. So pelvic TB peritonitis, peritoneal surface studded with the miliary tuberculosis. I think we all have seen all this because in India TB is common everywhere. TB is there. Pyohydrosalpinx may develop. Ampullary portion dilated with femoral end pouting, that is called as a tobacco pouch appearance. Everybody in their practice, at least once they have seen this tobacco pouch appearance. Who's Hicks-Cortex syndrome? I think everybody has seen once. Liver, there is adhesion on the outer surface of liver, hanging gallbladder sign, frozen pelvis. Once in our practice, we all have seen because it is very, very prevalent in India. Coming to interstitial, showing thickening of the tubes with inflammation, tubes becoming dilated. Tubes become dilated and they become retort shape. This is I think this word we are listening from our MBBS, a retort shape, loculated. And in chronic cases, we see beaded tubes with calcification and tubal blockage. So these we are well versed with these terms. We are well versed with salpingitis systemica nodosa. Again, we are well versed with. I'll not go very much into detail, but yes, these are findings on HSG. So here we can see that bilateral. First picture, it is showing that rigid pipe stem appearance. Okay, where there is a intravasation. Then on hysteroscopy, there is a pale endometrium with adhesions on hysteroscopy. Then on laparoscopy, here we can see that there is a multiple peritoneal adhesions. We can see in figure number 6. In figure number 7, there is a hanging gallbladder sign. Figure number 8, we can see there is a caseous nodule on the peritoneum. If it can make out. Then figure number 9, we can see laparoscopy showing the hyperemic congested tubes with multiple miliary tubercles. There is an arrow showing the tubercles. So these are the pathognomic findings of, we can never miss. These are the findings of tuberculosis or infertility caused by it. Now coming to causes of infertility, we have discussed till now about tuberculosis causing infertility or tubal factor of that. We will not go into the, because TB actually affects everything. It affects ovary, it affects tubes, it affects endometrium. But here we don't have, or we have restricted ourselves to tubal factor today. So we'll not go into that. We will now come back to causes of infertility and tubal factor. So it can be unilateral tubal blockage, loss of tubal functions due to ciliary damage, perisulfingritis causing adhesion or telomas formation, unilateral bilateral hydrosulfings with or without obstruction affecting fertility. Sometimes there can be hydrosulfings, but there is no obstruction. Tubes are swollen, but they are open. But again, it affects the fertilization and embryonic implantation. So pathologies are 36 of the percent. It is adhesion is the most common. Beaded tortuous tube. 20% is hydrosulfings. So always, so dear friends, always there is not hydrosulfing. TB is equal to hydrosulfing is not a picture. See, you can see that adhesion is the most common. Then there are dilated tubes, bilateral tubal block, and for 60% it is bilateral, 40% can be unilateral tubal block. So Fallopian tube or tube diagnosis is challenging, and isolation of a microbiome by culture is often unreliable. Genital TB may be diagnosed when one or two tests turns positive. Premenstrual endometrial aspiration or NAT test, TB PCR allows the diagnosis. So most commonly in today's practice, what we do is the TB PCR. PCR cannot differentiate between, but again here there is a restriction that it cannot differentiate between active and the latent infection, and hence the endometrial sampling and the TB stain. Bacterial culture, this is also there, the bacterial culture and the histopathological examination of tubercles, and diagnostic laparoscopy. If on the diagnostic laparoscopy, if we see that there is a pathognomonic lesion, then also we can put the patient on AKT. So diagnostic laparoscopy are used in conjugation with TB PCR. The new self-contained cassette-based analysis that is called Gene Expert is faster than PCR and helps in identifying rifampicin-resistant TB also. So Gene Expert is there. I personally have limited experience about Gene Expert, but yes, there are practitioners who are using Gene Expert in other than TB PCR. TB, when diagnosed, should be treated with ATT for at least 9 months. So this was about treatment. Coming to hydrosulfings. So we will be discussing detailed about hydrosulfings and what are the treatment options, what we have, and when we are going for IVF, what we should do, what we should not do. All we are going to discuss about this. So distally blocked fallopian tube filled with fluid is the definite, according to definition. Blocked tubes may become markedly distended, giving the tube a characteristic sauces or retort-like shape, and the condition is always bilateral. We have seen sometime unilateral, but the other tube may be not detected on sonography, but it is affected most of the time. Affected tube measures several centimeters in diameter. What are the causes? Again, prolonged untreated infections, STDs, unsafe abortions, abdominal surgeries, previous tubal surgeries, pelvic endometriosis, intrauterine devices, again, tubal tuberculosis. These are the causes of hydrosulfings. So tubes having inflammatory cytotoxins in the fluid of hydrosulfings are toxic, and they prevent the fertilization. This we all know, that there are some inflammatory cytotoxin in that hydrosulfing fluid. So the fluid of hydrosulfings can affect the sperm motility negatively. And in uterus, the retrograde flow of this hydrosulfing fluid into uterine cavity, it causes reduced expression of endometrial integrins alpha V beta 3 and HOXA 10, reducing the receptivity and affecting implantation. And also there is a mechanical disruption of contact between endometrial surface and endometrium, flushing out the embryo through the cervical canal. So hydrosulfing fluid may also cause increased endometrial peristalsis. So this hydrosulfing fluid is what we don't want as a IVF consultant, or when we are treating a patient with hydrosulfings, we don't want this hydrosulfing fluids, because it is not only affecting the tube, but it is affecting the embryos that we are going to put in the uterine cavity, and also the receptivity. Again, it is most of the time we think that it is a tubal pathology, it is not going to affect our ovaries, but there is ovarian dysfunction and can affect the natural conception more in the women with visible hydrosulfings on USG, increased chances of both failure or rupture of dominant follicle in the natural cycle and persistent of unruptured follicle in the follicular phase of next menstrual cycle. So if you are suspecting, if you are having a repeated unruptured follicle, you should suspect of some adhesions. Some we should, of course, for unruptured follicle, we should check for patients, AMH level. Most of the time PCOD or raised prolactin level can be the reason for unruptured follicle, but of course these mechanical reasons can be there, adhesions, then some kind of hydrosulfing which is not detectable on sonography, maybe, which is in the forming stage. So this can also lead to the unruptured follicles. Now coming to effect of hydrosulfings on IVF outcome. Presence of hydrosulfings before IVF treatment adversely affect the pregnancy rate and increases the risk of spontaneous miscarriage. In the meta-analysis of 1144 women with hydrosulfings, without hydrosulfing, implantation rate were less than 50% in the patients with. So presence of hydrosulfing could also affect the uterine and ovarian blood flow. Hydrosulfings, again, as I told, it lowers the endometrial vascularization and flow indices. So it is impairing everything. It is impairing endometrial and uterine blood flow and receptivity, oocyte quality. Everything at every stage it is affecting hydrosulfings. So this is the study of 2020, the retrospective analysis of ovarian response to gonadotropin after laparoscopic unilateral salpingectomy for hydrocephalus. So these are the patients in whom their salpingectomy has already happened and now they are undergoing IVF. So what they have seen, that the two groups showed no significant clinical characteristics such as age, AMH, and there was there is no significant difference in the number of oocyte retrieved. So they are saying that the patient who are operated, not operated, they are having the oocyte retrieval rate was same when their ages and AMH level were matched. But and the conclusion, if I can say, I have highlighted this, that significantly fewer number of oocyte were retrieved for IVF in women who undergone salpingectomy than those who had not. So it is affecting the quality and number of eggs that we are that we are receiving or we are retrieving. So also the peak E2 level were significantly lower in the patient who had undergone salpingectomy, and even though the similar amount of gonadotropin were given in the both the groups. So this is somewhere because of the blood flow to the ovaries is getting hampered because of the salpingectomy. So our dictum is, if the patient is there of the hydrosulfings, we generally do is we do her stimulation, we retrieve all the eggs and we freeze the embryos, then we go for salpingectomy and then we go for transfer. So this protocol is generally followed in the patients who are having hydrosulfing. So ovarian functions was adequate for the IVF after unilateral salpingectomy, but bilateral salpingectomy might reduce the ovarian function. I'll just go through it. So these are the tests. Now coming to USG evaluation of fallopian tubes. So clinical history examination in conjugation with TVS finding decide whether the patient has high index of suspicion for tubal disease. So dear friends, this is the line I want to quote, that healthy fallopian tubes are not seen on routine sonography. Most of the patient come to us, मैडम आपने तो सोनोग्राफी कर लिया, फिर उसमें नहीं दिखा क्या ट्यूब ओपन है कि नहीं. सो वी नीड टू एक्सप्लेन टू द पेशेंट कि ट्यूब्स जो है वो हमें नहीं दिखते हैं सोनोग्राफी में इफ दे आर हेल्दी. Okay, so whether it is a 2D, 3D, whatever sonography we do, we will not see the fallopian tubes. The characteristic retort shaped pseudo-septed appearance is diagnosed. अगर हमें सोनोग्राफी में ट्यूब्स दिख रहे हैं मतलब ट्यूब्स को पैथोलॉजी, इसीलिए हमें सोनोग्राफी में दिख रहे हैं. दिस इज द डिक्टम दैट वी शुड नो. And in the day-to-day practice, we should understand that if we are seeing the tubes on the sonography, that means the tubes are damaged or there is some pathology. Disease and distended fallopian tube are often seen as adnexal mass. I will show some pictures. So you can see the beautiful, it is seen on sonography, the distended tubes on USG. So no 3D scans are also needed. These, if this much distension is there, we can see it on the 2D sonography also. Thin and thick wall in the chronic cases, elongated retort shaped with distended structure. It is separate from uterus and ovary, so we can make out. Then cogwheel appearance from the thickened longitudinal fold in the heterosalping. There is a cogwheel appearance here, we can see, which is pathognomic of, heterosalping. And of course, bead of string is seen here. Bead of string I have not seen, but typical this picture of, hydrosulfings, we have, most of the time we have found this, and it can be confused sometime with, ovarian cyst. So we need to delineate properly that uterus, ovary, and the adnexa. So we need to always scrutinize, always, screen out the adnexa properly. Whenever we are doing a basic sonography of any infertility patient, uterus, ovaries, we always see meticulously, but we don't see meticulously is the adnexa. That is the tissue between the uterus and the ovary. We may miss some paraovarian cyst, we may miss some broad ligament fibroid, we may miss this tubal pathology. So always we should meticulously see the adnexa. So transvaginal sonography has an accuracy. I'll just keep, it is around 84% of the sensitivity is there. So coming to HSG, yes, we need to talk about HSG, though I don't do HSG, but HSG is still commonly widely used. So it is a widely used tubal evaluation for subfertile couple, and this method fairly accurate for detecting proximal, and it is not much expensive, and provides the optimal delineation of fallopian tube, allowing the detection of tubal patency, tubal occlusion, tubal irregularity, and peritubal disease. It is done in the proliferative phase. My dear friends, please, I want to highlight here that we need to ask the patient to do it before day 9, because sometimes there can be early ovulation also. The patient may have ovulation at day 10 also. So ask the patient to do it before day 9 or at least before day 10, because that cycle should also not be hampered for that patient. So it is done in the proliferative test to ensure that patient is not pregnant when procedure is performed. In addition, any ectopic pregnancy is obviate the unlikely possibility inducing ectopic pregnancy by performing procedure after fertilization and alteration of. So we should not do it in the luteal phase. And procedure is usually require no sedation. Some of the centers do give short sedations, while providing the analgesics prior to would seem advisable. But there is some data. So post-operative analgesis, we generally do. How it is done, we all know. Still, this is just revision. So woman is positioned under X-ray imager on the table, and then the uterus is examined, and the with the speculum, and cervix is cleaned. Then we put liquid containing iodine, and look, that can be seen by the X-ray through the cannula. That can be Rubin's cannula, and the any cannula. For that, number of cannulas are available nowadays in the market, and the contrast will be seen as a white on image, and can show the contour as the liquid travels from the cannula into uterus and through the fallopian tubes. So the contrast enters the tube, and we can see the spillage. So X-ray we generally take, and the side view of uterus, and can change the position, we can take the X-rays. So what are the contraindication are again pelvic infection, pregnancies. So these are the commonly we prescribe the medicine post HSG is a doxycycline for 5 days should be given. So HSG, it is an agreement with laparoscopic findings 2/3 of the time. So sensitivity is 67% and specificity is 83%. Tubal blocks seen on HSG will be confirmed by laparoscopy only in 38% of the women. So you can see that if at all we are finding tubal block and HSG, only 38%, less than 50% of the time that patient will be having tubal block. So we have seen that if the patient is having tubal block, rather than subjecting them for laparoscopy, they are again subjected for HSG. So this is not actually recommended. This is not a practice. Sometimes because of the affordability issue, we generally or the patient themselves take the second opinion. Then when the tubal block, because for them it is a big diagnosis, and then they go to some other practitioner, and then they will also एक बार और करके देखते हैं. But this should not be advised, because again it is painful procedure. Patient should be subjected, if at all there is a proximal tubal blocks, then patient should be subjected for laparoscopy and the tubal blockage should be confirmed. When HSG suggests that the tubes are patent, this will be confirmed on 94. So tubal patency, it is reliably indicated by HSG, but tubal blockage is not reliably indicated. This is the message I want to give from here, that if at all tubal blockage is there, we should subject the patient for laparoscopy rather than going for again for HSG, because we have seen patient one HSG showing tubal block, then other HSG showing tubal patency, then one more HSG showing unilateral and one bilateral. So this should not be, the management. Patient should be properly counseled that if at all it is HSG on tubal block, then we should go for the higher treatment. If it is patent, that it is patent. Sometimes patient may come to us that madam इसमें तो बोला है लेकिन laparoscopy करके देखते हैं क्या tube है कि नहीं. But if at all HSG is showing that tubes are open, that means tubes are open. Yes, of course, the some pathologies there in the cilia or all that we cannot make out on. So what are the disadvantage? Coming to the disadvantages, so here we are exposing to the radiation. There is abdominal pain. Abdominal pain, though it is that 5 minutes it is, but it is a painful procedure. And of course, intravasation can be there. Then there can be the HSG can be normal, or there can be some, it can be patent with tubal disease, or there can be tubal blockage. I will just skip through this slide. So this is the typical picture of good chances of future fertility. Low, this is the normal. Tubes are open here. We can see the bilateral spin. Then these are the tubes are patent, but there is some disease. There is a mid-tubal disease in 2A. Then there is some moderate tubal disease. So moderate prognosis and outcome is, somewhat higher incidence of ectopic pregnancy can be seen in these patients. Then blocked tube with several, here we can see that there is a several tubal disease. So here bilateral tubal block, we can see that there is a cornual block. Sometimes here we can see that there is a hydrosulfing. So when the hydrosulfing is detected on HSG, it is prudent to administer antibiotic to reduce the risk of reactivation of inflammatory process during this process. So whenever we are examining and we are doing HSG, most of the time gynecologist only put the dye. So if we are seeing that there is a hydrosulfing, then we should give them the proper antibiotics cover. And if there is a tubal occlusion at the uterotubal junction, then hydrosulfings may not be detected. Then of course tobacco pouch appearance can be there. There can be corkscrew appearance. So these are the typical HSG finding that we can see. Lead pipe appearance, beaded appearance. These are the all appearance that we can see. This is the salpingitis ischemica nodosa. Here there is a extension of tubal epithelium into myosalpinx, mainly in the ischemic portion, and appears as a nodular outpouching at the ischemic region. So it is a there is a reactive hypertrophy. So this is a typical HSG picture of, you can take a screenshot. Now coming to SSG. So this is my favorite procedure, SSG, because we routinely perform is SSG. So there is a ultrasonic observation of uterine architecture and endometrial lining and endometrial cavity interface following the installation of saline into endometrial cavity. So now here what we are doing in HSG, we were putting a dye and we were seeing the anatomy, whether it is tube are blocked, tube are open, what are the pathology of the tubes. Here what we are doing, here we are putting a saline, and under the sonography guidance, here we don't have the X-ray, we have a sonography. So under sonography, we are seeing whether the saline is coming out from both the tubes. So attempt to delineate the fallopian tubes during installation of various synthetic contrast is termed as histro. So sometimes the contrast material can also be used, that is called as a hysterosalpingo contrast sonography. So I'll come to that. There is some dye that is used. So contrast medium distance the endometrial cavity and provide the fluid interface and allows the identification of endometrial polyps, adhesions, leiomyomata, septa. So contrast sonography generally can be performed by gynecologist office using available ultrasound equipment. Major advantage is allow the visualization of extrauterine pelvic structures as well as more clinically delineated intramural and intraluminal abnormalities. It is faster, less painful, and less expensive than HSG. Of course, expenses depend upon center to center, and it easily allows both anterior and sagittal views, and it is generally reported to be accurate as HSG in demonstrating tubal patency. So, contrast agent generally we do is with the saline. I do it with only saline, but there is SonoView. So this is available in India also. The SonoView, what we can do is this contrast agent consisting sodium hexafluoride in the normal saline. So to assess the tubals, 1 ml of this SonoView can be diluted with 4 ml of NS and agitated, and then it is injected into uterus with the contrast appearance of white echogenic ultrasound. So color Doppler also we can put whenever we are pushing the saline, we can put the color Doppler. When there is a spillage of saline, we can see it on the color Dopplers. And when there is a hydrosalpinx, of course, there will be the tube turbulence. So, although tubal patency can be observed by appearance of fluid in the cavity with the saline, the test does not differentiate. Some limitation is that the we cannot make out. But yes, if at all we are, quick enough that when we are pushing on the first time, and we can see the spillage on one side and we cannot see the on other side, then we can diagnose. But of course, it is difficult to diagnose unilateral and bilateral patency. Now coming to how the test is performed, how the SSG is performed. It is performed again 6 to 11 days proliferative phase when the lining is thin, better visualization. And what we do is we first do the sonography, ultrasound, and we in the routine fashion we look for the uterus and ovaries. We sew for the antral follicle count, and thereafter the sonohysterogram catheter. SSG catheters we can get, or we can do it with the Foley's number 8 also. We need to insert that catheter or the Foley's number 8 inside the uterus. We need to inflate it with 4 cc placed in the cervical canal. Blood is inflated so that when we inflate that balloon, then it will not come out, and there will be the seal to prevent the backflow of the saline through the cervix. So this is the procedure that I'll like to play. So here we are fine. First we have assessed, then we can see here that if we can make out that the bulb is in the uterine cavity. Now we are focusing on the ovaries. Basically, we have to focus ovaries. And we can see this because the fluid is adjacent, fallopian tube is adjacent to the ovary. So we can see the spillage. I'll just run through this. You can actually see the spillage of, this is the SSG that we have performed today. And we have seen the bilateral spillage. I will just, if you can see, sorry, there's some shaky video, but if you can see, there's a white, gush that of saline that is coming up, and that white gush of saline is nothing but the spillage that we can see in the both the ovaries. See, there in the pouch of Douglas also, if you can see, there is a proper spillage is seen in the last few seconds. If we can make out, there is a proper, we can see the proper spurt of saline that is coming up. So this both the tubes can be proper if when the at the end of the SSG, when the fluid is more in the pouch of Douglas, when we flush from both the sides, both the tubes, we can see the proper saline spurting. So it is a very beautifully we can do it. So ultrasound is then performed while using and note the various defect. And after that, after we have seen the saline coming out, we can see for the uterine pathologies also. We need to just put some saline into uterine cavity, whatever we are flushing into the tubes, that saline only we need to push into uterine cavity, and we have to take out the catheter, and just we need to wait for a few minutes for the saline to settle down. And when it settle down in the uterine cavity, when it settle down in the uterine cavity, we can see if any polyp or septum is there. We can definitely make it out. Of course, we should shake the saline so that bubbles, if at all there, then we can, they can be visualized when they are seeing at the spillage. If the saline bubbles are seen on the peritoneal cavity, that means the tubes are patent. And if the bubbles accumulated in the dilated tubes, then the blockage of the distal and hydrosalpinx can be diagnosed. So it is a very, easy procedure. SSG is a easy procedure. I think most of you must be performing also. And with the ease we can, and non-invasive. Of course, we in our practice we give short general anesthesia. We give a short anesthesia or sedation we give to the patient, so that patient should have a proper pain relief. But some of the practitioner, they do it without anesthesia also. They do it at OPD level also. But generally, what I do is we do it with small general anesthesia, so that patient don't have, bad memories. Sometimes the patient will have the bad memories because of, this procedure. HSG is very painful. Then patient may, quit the treatment also. So we need to be always, have the, I think there is something on the slides. So we should always consider that the pain tolerance of the patient, how it is, because painful procedures, again, the patient will refrain some treatments, further treatments. Now coming to laparoscopy and chromoperturbation, it's a gold standard for diagnosing tubal patency and inflammation. I hope I'm not, boring you, or we will go through this laparoscopy, and then we will come to the salpingectomy, and how we manage the patients for ART. So go gold standard for diagnosing tubal patency and inflammation. It is a minimal invasive procedure allowing the visualization of pelvic anatomy and pathology, and spillage of dye from the tube is actually seen. So it allows the diagnosis and assessment of management of peritubal disease adhesions. Of course, these things can be missed on HSG also and SSG also. So these things can be, diagnosed on laparoscopy only. Laparoscopy also enables us the biopsy. And then, although the laparoscopy is considered as a standard, it is not without errors. 3% of the time when we have diagnosed block, they can spontaneously conceive. Laparoscopy requires GA, then surgical skill, of course, and it is advocated in the women who have suspected tubal fertility having comorbidities like PID, previous ectopic pregnancy, endometriosis. So laparoscopy has a distinct advantage that it can be complemented with hysteroscopy, falloposcopy, salpingoscopy. So main advantage of this laparoscopy is we just don't see. HSG and SSG are only diagnostic procedure. We can only see. Here we can see and treat. So major difference between HSG and SSG, they are the diagnostic procedure. Here, along with diagnosis, we can treat the patient. So it can always be see and treat also. If we found some polyp, hysteroscopically we can do polypectomy. If we found some adhesion, we can release the adhesions. So these are all things we can do. If at all PCOS ovarian drilling is planned, of course it needs to be planned and it needs to be conveyed to the patients. It should not be on table, on table decision. It should always be planned. But if at all that is planned, then PCOS ovarian drilling also we can do. So the laparoscopic criteria to diagnose and grade the salpingitis. So minimum visualization criteria to diagnose is there is a tubal surface hyperemia, tubal wall edema, exudates, presence of exudates on the tube. Then mild salpingitis, there is a minimal visual criteria, mobile tubes and patent ostia. Moderate is when we see the patchy fibrin deposits on the tubes, and there is the tubes are not freely mobile. There is a moderate And in severe salping, that is, of course, we know that there is a dense adhesion, pyosulpings, and tubovarenopsis. Coming to chromoperturbation demonstration and document the proximal distal drug, and procedure can also identify and correct the tubal factors such as femoral phimosis, peritubal adhesions, and which may not be identified with the less invasive procedure. So, as I already said, hysteroscopic selective, if at all there is a proximal block. See, for tubal cannulation should not be actually advised for the distal blocks. It should be, properly concealed to the patient, that distal blocks will not, respond to our procedures or whatever laparoscopic procedure we are. If at all we open them also, then also the cilia or the functionality of the tube is actually questionable, and there is actually more chances of ectopic pregnancy. But of course, in the patient with proximal tubal block, we can try hysteroscopic tubal cannulation, but of course the success rate is around 40. I will say 50% around when we are trying for tubal cannulation. We'll confirm with proximal tubal occlusion suggested by HSG. Then we can think of recanalization. Uh, so this is the specificity and sensitivity of different tests and their complications. Then coming to management of tubal infertility. So deciding the management depends upon, again, whether it is unilateral, whether it is bilateral, whether it is proximal, distal, whether it moderate, severe, of course, age of the patient, duration of the patient, ovarian reserve, and what is the patient priority. Then presence of other fertility fracture, experience of in tubal surgeries. Of course, nowadays, because of the IVF success rate, it is so much successful. The earlier we have seen tuboplasties happening, laparoscopic tuberculosis, but these are declining. Why? Because more promise is seen with the IVF as compared to tubal surgeries. The success rate of IVF program and restoration surgeries. So, in the coming to this paper, this is the role of tubal surgery in the area of assisted reproductive techniques. This is the 2021 Fertility Journal. So, IVF and embryo transfer remains the ideal therapeutic options to achieve the intrauterine pregnancy in the women with tubal infertility. Ideal management of severe tubal disease, especially with hydrosalpinx and severe femoral fibrosis, is always IVF NAT. Most of the time, we have seen that patient is diagnosed with tubal factor, patient has diagnosed with hydrosalpinx, but again they go for some other laparoscopic surgery, some tuboplasty. But as you can see, there is a direct recommendation that IVF NAT for severe tubal pathologies, it is the treatment of choice. Women, I think there is some kalpanam. Yes, now it has gone. So women with mild or unilateral tubal disease may benefit with treatment approaches. So in the unilateral tubal blockage, we can think of going for IUI, of course, but again the success rate is less in the patients with unilateral tubal blockage. There is always a question that if at all there is a tubal block on this side and if the egg is forming on this side, then what we should do? We should do or IUI or not. We actually, the egg is going into peritoneal cavity. It can be captured by the other tube, but again the chances of conceiving in that cycle is again less. But yes, we cannot deny. We can ask the patient. Yes, we can do the IUI. It is not contraindicated. Practically, these questions comes to us as a fertility consultant that मॅडम या साईडची ट्यूब ब्लॉक आहे पण तिथेच एग बनलाय, मग आययुआय करायचं की नाही, की कॅन्सल करायचं या महिन्यात. बट yes, we can do IUI because egg is going into the peritoneal cavity, but of course success rate is less. So tuboplasty in the patients who cannot afford IVF can be done. Reconstruction surgeries, of course, benefit obtained from the tubal surgery would be potentially be sustained for many years and allow the conception through IUS. But it requires skill. Efficacy has weighed against the cons of expenses, and risk of tubal pregnancy is also there when the patient is operated for reconstructive surgeries. And tubal restoration surgeries are most effective in the younger. See, so which patient to offer the tubal surgeries are the younger patients with mild to moderate tubal disease. So And again, if at all, the surgical expertise is available with us. So, proximal tubal cannulation, I already talked about it, that hysteroscopic proximal tubal cannulation can be tried, and if it is due to tubal debris, sludge, and if at all it is not manageable, if it is not, we are not able to do tubal cannulation, then the procedure should be abandoned, because again it can cause the tubal damage. If the outer if the tubal blockage is confirmed, inner catheter with the flexible guide wire is advanced through the proximal tube. Before performing this procedure, it should be confirmation of normal distal tubal anatomy should be done. That means, if only the proximal tubal block is there and the other end of the tube is normal, then only we should try going for removing that proximal tubal block. Otherwise, it makes no sense. If the obstruction is not overcome by tubal cannulation with gentle pressure, a true anatomic occlusion is assumed and the procedure should be terminated, because if at all we are trying it aggressively, it can damage the tube further. So in these cases, again, IVF should be the preferred option over the resection and microsurgeries. Microsurgeries, earlier they were done, but nowadays, with the promises of IVF success, they are not done routinely. Among those tubes with the patency, for which patency is achieved, approximately one-third will occlude. The incidence of tubal perforation during the tubal cannulation has been reported to be around 3 to 11%. So while performing these procedures, tubal cannulation, we should also be vigilant. So tubal procedure is similar to in fluoroscopic or hysteroscopic guided we can do. Tubal resection and reanastomosis. This I'll just skip through. Again, here tubal resection and reanastomosis. Rather going for that, IVF-ET is a better option. Tuboplasty is not appropriate for the patients with severe tubal disease. Surgeries for distal tubal blockage. It is again having a poor prognosis, and there is a as you can see that there is a poor pregnancy rate and implantation rate in the patients with presence of hydrosalpinx. So, why there is a poor pregnancy rate? Because again, we have discussed this in the hydrosalpinx that there is a flushing of embryo, there is a decreased endometrial receptivity. So, if there is a communicating hydrosalpinx, the salpingectomy should be considered, or tubal occlusion should be considered. This is very important, that the laparoscopic salpingectomy or tubal occlusion should be considered before IVF for the women with communicating hydrosalpinx. Even the patients with unilateral hydrosalpinx have shown to have lower pregnancy rate with IVF. Unilateral salpingectomy result in the significant improvement of the IVF pregnancy rate in these patients. So it is important that if there is a hydrosalpinx, then it should be first salpingectomy or occlusion should be done, and then we should go ahead. It should be noted that there has been several case reports of spontaneous pregnancies after salpingectomy, urinatal hydrosalpinx also. Proximal tubal occlusion was also effective effective in restoring IVF pregnancies after hydrosalpinx. So there is a theoretical concern of proximal occlusion can lead to increase in size of hydrosalpinx as the fluid can no longer be drained. So ultrasound guided aspiration at the time of oocyte retrieval, actually it is not recommended because there are more chances of it getting recurrence, and simple aspiration either at the time of diagnosis or at the time of retrieval has high rate of fluid recurrence. So most of the time we see that there is a fluid filled hydrosalpinx, but it should not be aspirated. Sclerotherapy, of course, instilling the ethanol can be tried, and it helps in recurrence of the toxic hydrosalpinx fluid. It appears that the intervention to decompress the hydrosalpinx by ultrasound guided aspiration is superior to no intervention at all, but sclerotherapy may be superior option, and salpingectomy remains the gold standard. So whenever we are seeing that there is a hydrosalpinx, salpingectomy Again, we will come to the discussion of whether salpingectomy or only clipping, that we will come to. And but yes, of course, aspiration should not be performed in the patient because it has a high, high recurrence rate. Surgery for sterilization reversals, these were performed open. I have done open, open reversal, tubal reversals. We have seen pregnancies, but of course, the success rate with IVF is more as compared to the reversal. Most of the patient come to us, those who are not affording for IVF, they come that madam tubal reversal operation करायचा आहे. So, reversal of the tubal ligation is achieved by opening the occluded ends of the proximal and the distal segment and anastomoting them with fine monofilament sutures using magnification microsurgical techniques. Reversal sterilization, I will come to the conclusion. Reversal of sterilization procedure performed with rings or clips. So, rings किंवा clips असेल, if they are there, then results in higher pregnancy rate than the sterilization via the coagulation or ligation. So patient's age is the most significant factor. Pooling pregnancy rate is around 90% within 2 years of the microsurgical reversal, and 40 to 45 age, the pregnancy rate is around 45%. Generally, we don't advise. Generally, in the younger patients, yes, of course, we can think of, but for the older patient, of course, there can be the issues with low AMH. So these patients should not be advised with tubal reversal. Length of the tube that is achieved is very, very important. That surgeon, after the reversal procedure, if we are getting at least more than 4 centimeter length, then only it is, going to give us the pregnancy. Otherwise, it is not going to give us the pregnancy after, we have done the tubal reversal. Rate of ectopic pregnancies also increases, and of course, her going, if the age is less, then their pregnancy rate is good than those who are undergoing IVF. So it is important. The age is the very deciding factor if we are suggesting the surgery. Destructive tubal surgery is followed by IVF. So for severe bipolar, severe and bilateral tubal disease and hydrosulfings, presence of unresolving hydrosulfings is a pathognomic and has a poor IVF outcome. Now, we have come to the situation where we know that the patient is having hydrosulfings and we have subjected her to IVF. But in such cases, tubal going for salpingectomy, tubal occlusion, or clipping followed by IVF is a preferred treatment to conceive. So all the sonologically detected hydrosulfing should be removed and or occluded prior to applying ART. So IVF is developed primarily for, first IVF was performed, of course, we all know that it was performed for tubal infertility, but IVF outcome are poorer in the patients with tubal disease and in the hydrosulfing because there is a implantation rate are poor and the miscarriage rates are high. I'll just go through. So here, as we can see that laparoscopic salpingectomy is a preferred approach, but tubes is delinked, can be delinked. Sometimes, there can be much of adhesions and we are not able to perform salpingectomy. Complete tube removal, we are not able to perform. In this case, we can do is just tubal delinking by coagulating and dividing the proximal tubal tubes from the close to cornu. So always close to cornu is very important because we have seen, cornual ectopics can happen if at all we have done delinking also. So it is close to cornu is very important when we are doing the delinking. Mesosulfings is then serially coagulated and cut, staying close to the tube and avoiding the compromising the ovarian blood. So whenever we are doing the salpingectomy, we should always keep in our mind that we should not compromise the ovarian blood flow. Now coming to the salpingectomy, then advantage, disadvantage. So these are the procedures that we can subject to the patient who are going for IVF. Before that, salpingectomy, tubal occlusion, aspiration, salpingostomy. Of course, aspiration and salpingostomy are nowhere in the question. We should not do that. Comparing between salpingectomy and tubal occlusion with electrocautery or clips. So salpingectomy here, total removal of the chronically inflamed tissue is happening. So here we are totally removing that tube. No further risk of abscess formation there, and increase accessibility to the ovary for pickup if at all further required. And but again, it is a invasive procedure, and if at all, sometimes it may be difficult in the cases of frozen pelvis. We may not be able to delineate all the tube, so it may be difficult. And just a minute. Uh, So interstitial cornual pregnancy or rupture may occur. Then it may hamper the ovarian vascularity. Tubal occlusion, it is less invasive, easier than salpingectomy when desudation are there, but risk of abscess formation and torsion is there. So a surgical treatment who for this is one of the paper. I think I should skip it. I'll just go into the conclusion of it. So they have compared the patients who have undergone salpingectomy and those who have not undergone any treatment or no intervention was there. So live birth till live birth rate, the data is not available, but here they are saying that the clinical pregnancy rate was more in the patient who have undergone salpingectomy and then undergone for IVF than who have not undergone any surgery. This suggests that the woman with that in the woman with clinical pregnancy rate of 19% without tubal surgery, and that and with salpingectomy it is around 52%. So of course there is an increase in the pregnancy rate. Proximal tubal occlusion versus salpingectomy, we have already discussed this. Proximal tubal occlusion versus no surgery, we have already discussed this. So of course the take home message from all this discussion is that as compared to no intervention, tubal occlusion is better. As compared to tubal occlusion, salpingectomy is better. This is the spectra. But of course, if there is dense adhesion, we are not able to perform salpingectomy. We should go for tubal occlusion at least, so that it will be delink, or it is called tubal delinking also most of the time. So this is again a paper. I think I'll just jump into conclusion. So here, what they have done is a Oospheere. I think everybody must be knowing Oospheere. So they have put an Oospheere for tubal occlusion, and they have compared it with the salpingectomy. But here they have seen that Oospheere has lower pregnancy rate as compared to laparoscopy. So whenever you have in dilemma that whether for occlusion should I put a Oospheere. So here is the data that Oospheere has lower pregnancy rate as compared to salpingectomy. Hysteroscopic tubal occlusion with bipolar we can perform. If at all there is a frozen pelvis, there is no scope of putting a scope. If it is a frozen pelvis, we have seen such patients where there is a total frozen pelvis. We are not able to, patient is operated already 2 or 3 times, but still their hydrosalping is seen. Then we can do is hysteroscopical tubal occlusion. That can be done with the help of hysteroscopic. We can occlude the ostia, but of course there is a chance that it can reopen again. It is not a permanent as tubal occlusion, but yes, hysteroscopic tubal occlusion also we can do in the patients where a laparoscopic approach is not possible. Then treatment of hydrosalping in relation to IVF or systemic remove. I'll directly jump to the conclusion. So here they are saying that the live birth rate, clinical pregnancy rate are higher in the salpingectomy patient, so, as we have already discussed. Oospheere, again, there is a live birth rate is lower in the patients with Oospheere. Hysteroscopic placement of Oospheere device to treat the hydrosalping before IVF procedure has an inferior pregnancy outcome. Coming to the summary. So, PID causing salpingitis and tubal infertility should be diagnosed early, and treatment following the CDC guideline. HSG is recommended as a first-line treatment test to assess the tubal patency, but when available, sonohysterosalpingography using saline or uh, uterine cavity, uterine cavity and the tubes should be preferred. Laparoscopy with chromoperturbation is a gold standard to assess tubal pregnancy and is a first line for the woman with history of pelvic comorbidities like endometriosis and PID, IVFT is the best option for the patients with severe tubal disease. Tubal cannulation is recommended for the proximal tubal obstruction in the younger woman with isolated tubal factor as it restores the patency. Tubal reconstruction surgeries like uh, new salpingostomy or fibroplasty improves the fertility in young women with mild distal tubal disease. So I have not discussed about these surgeries much because again it would have been lengthy. Then laparoscopic salpingectomy and or proximal tubal obstruct occlusion is recommended prior to IVF in all cases of sonologically detected hydrosalping and severe tubal disease to improve the IVF pregnancy outcome. So these were the take-home message from my side, and thank you so much for your patience hearing. I hope I have not bored you all.
No, no, no.
Anybody is
Kanchan,
awake?
Kanchan, you have spoken for almost 2 hours, and
Sorry.
you have almost given us a textbook on tubal infertility. Everything under the roof for tubal infertility you have covered. So
Yeah, I
your
know that you
slides,
have.
we can combine your slides, and whatever is the material, we can have a small booklet on tubal
Sorry.
infertility. That is the kind of efforts you have taken for us, and
Yeah,
all the delegates who have attended will be very happy to have listened to you, and they'll be very happy to get your slides also a little later, because
sure, sure.
they are a complete textbook on tubal infertility. Uh, I invite questions to Kanchan. If there are any questions on the in the chat box, Kanchan, can you see that?
Yes, yes, I can see. Time between ovum pickup and salpingectomy and embryo transfer. So generally what we do is if we are planning, if we are diagnosed case of hydrosalpinx, what we can do is we can do the pickup, we can freeze the embryo. In the next month, next period she is having, that period we will do the salpingectomy. In the next month, the next coming periods, we can go for embryo transfer. So it is not like we need to wait for 3, 4 months, nothing like that. We can immediately go for transfer next month.
And so many carry-on messages have come. Like I have learned today that almost HSG is out now, and sonosalpingography is one thing. So you all do it in your own clinics where you give a short GA and do
Yes, yes.
saline
Actually,
based, or anything else that we have in our in our OTs in common. Like I have seen people using betadine
yes,
for
yes. We put some betadine so that it can get visualized. We make some froth. We shake it so that it becomes, more easily visualizable because we can see that dots, froths in the on the sonography. It can be detected better.
This thing that you talked about, hysteroscopic tubal occlusion with the help of bipolar.
Yeah, yeah, yeah.
How common is it, and how, because I have a patient who's got she has been operated when she was very young on the small intestine. For what reason she also doesn't know, and she has got chronic ascites now. She's got three
Hmm.
failed IVF cycles. So what I told
Hmm.
was, now what can we can occlude your tubes because there is
Hmm.
ascites. Maybe
Hmm.
just as you say that a hydrosalping can cause problem, I feel that even the ascites can cause problem in the implantation. Now her pelvis is totally frozen. So can we do something hysteroscopically to occlude the
Yes,
tubes?
yes,
Will this
definitely,
work?
sir. If at all we cannot assess it laparoscopically, we can definitely occlude. In previous institute where I was working, we have done this that we have occluded with the bipolar that ball is then a ball of
Bipolar
resectoscopy.
ball. Okay.
Ball, yes. With that ball, we can, just occlude that proper ostia. We have to completely occlude that.
Hmm.
And we have seen results with that also.
Okay. So now here a little bit of that coronal area is going to get cauterized. So does that hamper the implantation? No.
Just only that ostia area, sir. Not much than that. Only that ostia. In cases of septum dissection, also we use the
Okay.
bipolar cells. So after that also the patient conceives, so not a problem. And if at all you are using energy inside the uterus, that is
Mhm.
not going to hamper. Patients do conceive.
So thank you very much, because this patient is going to follow up with me tomorrow. So good
Mm.
that, yeah, I listened to your talk today. I can give that option to
Thank you,
her
sir.
of doing a hysteroscopic occlusion with the help of bipolar. Any more question? Anybody wants to ask a question directly? Is there anybody?
I think it went very lengthy. I am sorry for that.
Not at all. Even we are sorry that you have been speaking for 2 hours almost. So we are sorry we made you talk for so long. But let me assure you, you have done a wonderful job, and I am going to take your slides and keep it as my armamentarium for any future talk on tubal infertility. So
Sure,
great
sure.
job done, Kanchan.
Thank you.
And I
Sir,
am,
I wanted to ask
yeah,
something.
please go ahead.
Sir, I'm Dr. Ranjana Shintri. Wanted
Hi,
to
hi.
basically thank Kanchan ma'am. She has definitely done a very good job. As you said that she is like given the information as much as a textbook gives. So very nice. One more thing that every time we are reading the statistics of tubal factor infertility is 30%.
Hmm.
But is it really 30%? We need to introspect because whenever we are seeing patients in the OPD, I find it's like 10 to 15% only.
Yeah, yeah. See,
Most of the
nowadays
time,
the trends are, trends are changing. I thought like 90% of the patient, मतलब before tubal testing only, I tell them that tubes will
yeah,
be
it's
okay
going to be
only.
normal. Correct.
Yeah, it would be normal only,
Why
but
do
we
we
need to
always label
confirm.
it as 30%? That's my question.
Yeah,
Whether it is the functional part, like we can never assess the cilia and all.
yeah,
The
correct,
are
correct.
just open, but they are not
See, What,
working.
what, what we have seen now, patients with two IVF failure, they have subjected to lab clipping. We have seen that also. That
Okay.
no, nothing we can find.
Yeah.
And if at all that center is not, or the consultant is not comfortable with PGT and ERA, then they go with lab clipping. They clip
Hmm.
their tubes. Normal tubes are clipped, suspecting
Okay.
that
Have
there is
you,
something.
Kanchan, has anybody done a study where there were two or three implantation failures and
Hmm.
everything was normal? There was,
Yeah.
as Ranjana was saying, there is nothing to suspect a tubal factor, and
Yeah.
somebody did a lab clipping, and then the success rate was better.
I'll have to search for such, sir, because this is not recommended. Nowhere it is recommended. See, I have read all the
And
recommendations now.
also, it will be difficult to convince the patient to go for a
Correct, right?
clipping
No, no, they
surgery when the tubes
do.
are normal.
It
Yeah, yeah.
it is
So
done already. It is done.
Okay.
Two IVF
because
failure,
that
go for lab.
involves a surgery, isn't it, Ranjana? So it will be very difficult in the
Yes.
consulting room to tell someone that you undergo this thing because you are having repeated failures. Yeah, I understand.
Yeah. Sometimes there can be, not detected issue that are there on sonography. We cannot detect, and sometimes we can see that on, laparoscopy. Uh, but
Yeah. So,
yes,
so while you are doing a diagnostic laparoscopy, don't call it a diagnostic laparoscopy, call it
yeah,
an fertility enhancing
Yeah.
laparoscopy,
correct,
so
correct.
that you take a consent for anything fertility enhancing, and then you find something on table that the tubes have got hydrosulfing, then you will have a reason to do the clipping. See, what many of the infertologists do is they take consent for diagnostic laparoscopy. Now, diagnostic laparoscopy does not include clippings, so you take a consent for
Hmm.
fertility enhancing laparoscopy, so that if there are some adhesions, you can remove them. If there is this kind of a finding, you can do a clipping. So
Hmm. Sir,
that
one
way you can.
question from my side. If at all we have not seen, मतलब we have, if at all the sonography have missed hydrosulfings, and on table we cannot do the salpingectomy, na?
So that's the very reason why I'm telling you, when you take a consent for when you're putting in a tube for infertility, don't
Hmm.
call it just diagnostic, because a diagnostic laparoscopy means that you're going to see and come back.
Hmm.
You sit with the patient and then tell her that there can be unforeseen problems like
Hmm.
like a hydrosulfing. You should have a proper consent with you that
Hmm.
things like like a hydrosulfing may be seen, and then you
Hmm.
talk about the advantage of clipping in case you already decided to do an IVF,
Because
right?
we have seen the patient that in one setting only diagnosis of bilateral hydrosulfing has been done, abdomen was closed, and the next setting
It
they have
should be.
done.
It should be like that. If you had taken a consent only for diagnostic laparoscopy, then you have no business to do a clipping, even if you found a
Hydrocephalus.
hydrosalping. You have to take another consent for that and then do it. Otherwise, you did the clipping, and tomorrow the patient might sue you for doing something which for which you have not taken a consent. So that's the very reason why, especially not about general gynecologists like me, I can do a diagnostic laparoscopy, but infertologists like you, when you are putting in a scope, sit with the patient for some time and tell them that I'm going to do a fertility enhancing laparoscopy. If I find, say, endometriosis, I'm going to burn it out. If I find that the ovary is, ovary which justifies those cauteries, ovarian, you'll do drilling. So I'm going to do that. I mean, you have to sit with the patient. There is a difference between a general gynecologist doing a laparoscopy and infertilologist doing a laparoscopy. So from now on, when you're doing laparoscopies for your infertile patients, sit with them and tell them such things might come up. And for your benefit, I'll do a fertility enhancing surgery like an ovarian drilling if indicated, like a clipping if indicated, and things like that.
One more question, sir, I have,
Yeah.
Kanchan ma'am.
Yes.
It's like, what is the more common cause for PID, like which is affecting the tubes? Whether you would call it tuberculosis or it is a more of the chlamydial infection.
No, still today, chlamydia comes first.
Chlamydia.
Yeah.
Okay. So we are just doing that chlamydia NAT test.
NAT test, yeah.
Usually we are not doing any testing for chlamydia.
Not doing. They are directly giving, or we are suspecting, then they are directly giving. We are not doing tests, yeah. In practical, we are not doing.
Okay.
Sir, I had one question.
Please, Dr. Margi.
Yeah, this is Dr. Margi. Yes, ma'am. It was a very nice talk, ma'am. You covered actually almost everything. We enjoyed it. So, ma'am, we had one patient. In sonography, she had dilated, like typical retort-shaped tubes, hydrosalpinx. And the patient verbally told that she had 10 years back history of TB, but she did not have any documents of that. And she was advised AKT, but because of intolerance, she didn't take it. And so this time she had thin endometrium also. So we gave HRT, and in luteal phase we did people biopsy for TB culture and TB this PCR. But both have come negative. So is there any possibility that she is still having active pelvic TB but her endometrium is not showing TB?
See, up at all, we give anti-TB medicines also, no? This for anti-TB medicines, this is not going to treat her thin endometrium. For that, generally the vascularity is compromised. No? So you can think of going for hysteroscopic PRP, metroplasty and PRP. That is a better option rather than going for again for 6 months or maybe 9 months of ATT and again prolonging her procedure. If at all thin endometrium is bothering, her embryos are formed, I think, na?
No, ma'am, we have to, she is for donor. So first we were waiting for this only.
Endometrium. So you can think of endometrial PRP, hysteroscopic PRP, platelet-rich plasma installation.
Okay, ma'am. And no need to diagnose like active TB, like pelvic, because before transfer, we need to occlude the tubes also. So we are worried about that frozen pelvic.
Laparoscopically, you occlude her tubes. Best. It is selfing.
So at that time, no need to take biopsy and again check for TB, no?
No need.
Okay, ma'am. Thank you.
Doctor, I would like to add, but then before doing PRP, if you've not done a hysteroscopy, please go for a hysteroscopy first, diagnostic.
No, hysteroscopic guided PRP, I'm saying. I'm saying that subendometrial hysteroscopic guided PRP.
Yes, because sometimes inside the cavity, then we see small tubercles or small something lesions. In that condition, then we cannot do a PRP actually. When we are seeing some pathology inside.
See, in the long-standing cases, generally in the active cases only we will see the tubercles and all. Routinely, we don't see actually. We see only is the compromised vascularity. The endometrium will be pale. Or you will see some chronic endometritis, hyperemic endometrium. Otherwise, you will just tubercles. I have rarely seen, miliary tubercles in the hysteroscopy actually. If at all anybody has the experience, please share.
I had a similar case. I had a patient whose transfer was being postponed every time because the endometrium was remained to be very, very thin. So then I put a hysteroscope and I found that there were multiple tubercles. It looked like TB only, but then the reports and all came negative. So we could not start her on any anti-gox therapy also. But then we gave her empirically antibiotics, cephalosporin, soda, masala we had given. And after 14-21 days, only 14 to 21 days antibiotics were given. And then again I did her hysteroscopy. And believe me, it was all gone. It had all vanished. And suddenly the 3 mm endometrium went up to 8 mm endometrium. And we did her transfer and she conceived also.
Very nice. Yeah. Nice.
That was the only experience which I had. So because I was also planning to do PRP, hysteroscopically PRP, I was planning to do for that patient. But when we did hysteroscopy, we found that there are tubercles, there are a lot of endometritis is there. So then I did not go for PRP. I just postponed that. I just did a diagnostic. I just took the biopsy of those tubercles and sent it for testing. What I mean to say is whenever there is an active infection, if you're seeing in the cavity, you should not go for a PRP.
Yeah, that is there. That is there. Of course.
Yeah.
Okay, ma'am. Thank you, ma'am.
Great, wonderful discussion. Any more questions? For me as a general gynecologist today, my carry-home message is first stimulate, then self-injectomy, and then embryo transfer. This is the carry-home message I have got because I am not an infertility specialist. I did not know that you have to first do stimulation, get your eggs, otherwise you will not get good eggs if you did a self-injectomy. So thank you very much, Kanchan, for making these very simple things clear for me. Anybody, Deep is wanting to ask something? Is there someone? Please unmute and ask. No issues. Deep? No, I don't think he's again muted himself. Fine. So thank you very much, Kanchan, and thanks to all the participants for being here. Kanchan, continuously more than 20 people were there listening to you, and they have all benefited. Thanks a lot for
Yes.
a wonderful.
Thank you so much, Oospheere team, and all the consultants who have joined in. I hope I have put at least 5% new inputs in your day-to-day practice. That is more important, that we take home something new for our day-to-day practice. I know everybody is practicing infertility because infertility is on a rise. So everybody is practicing, but we need to know what are the recent recommendations, what are the things that are going on, and what need to be done best for the patient. That's what we are all here for. Thank you so much.
Thank you, and let's all wait for the next week. Now we will soon announce who's going to talk on what subject. So until the next Wednesday, 4:30 p.m. Bye bye to all of you.